Really, I just a couple of things on kind of the history. You know, we never want to forget kind of where the technology came from. You know, it was this guy, Dr. Solomon, an interventional radiologist, who realized that, hey, maybe in the lung space there's an opportunity to use assisted navigation. If you think back into the 90s, even in the early 2000s, all of navigation was done by, you know, just advancing or extending tools to the periphery, and a lot of times if on a CT it looked like you could get there, it was still just a 50-50 coin flip whether or not you were going to get a diagnosis. But it was Dr. Solomon who said, hey, I'm going to put a sensor on the end of this scope and use the 3 orthogonal CT views to help me triangulate using a magnetic field to get an EM trackers to get to a field. Well, this technology developed it, and they found a more applicable space actually by a cardiac company called Biosense Webster, and they developed this technology into what was EP mapping in the heart, and eventually sold to J&J back in the 90s. The specific technology that's on the Illumnisite system was developed in the mid-90s, and it was first used in fighter simulation for pilots, fighter jet pilots, and it was basically allowing them to kind of simulate flying a jet. And then shortly after that, they thought, you know, maybe we could use this in toys. But what they realized that the technology was a little bit ahead of its time. Those little sensors where you see in the bottom left picture or in the middle there, long and narrow sensors, those are very expensive, and I don't think they calculated like how expensive it would be to build out toys. I think it was just technology that was a little ahead of its time. So then they initially moved it into the cardiac space to sort of compete with that Biosense Webster idea. But then shortly after, in 97, 98, they moved into the lung, and then clinical studies were first created to animal studies in 2002, and this is the first system that was created to use in those animal studies. What I want you to make note of is the picture on the far left. This is still in our what's called our locatable guide today, right? That's this device right here, and on the end of this locatable guide are those 6 tiny coils and windings, and you can see all the wires running to them, the sensors, and then on the proximal end, on the bottom end of the picture there, all those wires are braided back, and that's what comes all the way back to the tip where you plug a cable in here, and that's our locatable guide. So that was the first system. We weren't using these catheters back then, it was a different catheter. But then the clinical studies moved to Heidelberg, Germany, and first patients were done in Israel, and the first patient was actually done in Israel in 2003, 2002, published in 2003. 2003 they did the pilot study in humans in Germany. On the far right is Atul Mehta from Cleveland Clinic. And then he brought the first study here in the United States. Tom Gilday and Atul Mehta did this first prospective study of 60 patients, and really proved like, hey, there's a real opportunity with this technology to make a meaningful impact in the lung. And then we've got just a kind of a brief timeline of this navigation platforms. You can see first in the United States approval was 2005. With on the far left, it was called our version 4 system. And then, you know, if we look at 2010, 2012, that was a big, I was here, that was a big timeline for innovation. It brought about this automatic registration. It brought into vogue this whole catheter technology, right? A curved catheter that could be a single operator to navigate. And then in 2018, this is really, in my nearly 18 years here, this is where I got most excited. The fact that we were now able to integrate imaging, we could actually see the nodule, this mentality with users that, hey, if we can see the nodule, we're gonna get a diagnosis, right? Like that was kind of the excitement that surrounded it. And then in 2020, we launched Illumnisite, and that's what we're gonna play with today. So gives you guys a little bit of a timeline of the innovation and on how it got here today. Clinical data. So let's talk about Dr. Dunn's paper. Maybe Dr. Dunn could talk about Dr. Dunn's paper. Because this was the first, patients with Illumnisite that were actually done in the United States. Were done here at ECU, and you can see the top line there: overall diagnostic yield of every 87.2%. And I think, Dr. Dunn, you could sort of attest to the strict definition of diagnostic yield that was used in the ATS consensus statement last spring, suggested this very rigor of how they classify diagnostic yield. So things like inflammation and infection and are all thrown out of the equation. So you have to throw those patients out when you determine diagnostic yield. And I think it's more about, hey, what's actionable, right? I think that's maybe a term that could be used to say, we'll count it if it's actionable. So what I learned from this study is if you look at some of these patients were performed under conscious sedation, and actually I think the only cancers that were missed were those that were under conscious sedation. Is that correct?
I think that's correct.
Yeah. So the other thing that I took away from this was, again, if you look at nodule size, not small, right? But still, it's a first study. You kind of take on what you're dealt, right? These were consecutive nodules that came. The thing that you guys need to be aware of in these studies, though, is you got to look at more than just the diagnostic yield. So, for example, you guys are in an area where, I don't know, maybe less than a mile away is the first tobacco field. Like, lung cancer prevalence is real, right? So when you have lung cancer, it's always easier to find lung cancer, right? When somebody's got to throw out these infections and you've got more infection patients, now diagnostic yield comes down. So then first experience at Vanderbilt, right? So Vanderbilt had a diagnostic yield a little bit lower. Again, lung cancer prevalence wasn't the same. This was their first experience in 100 nodules, you put more users into the equation, you throw out more infections, blah, 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 you get this. You see overall diagnostic yield, second line down, is a little bit lower, and that's because there were some patients where they did not use the fluoroscopic navigation technology. They didn't incorporate the imaging. They went back to their super D habits of navigating out. I'm going to put radioprobe in this 3.5 centimeter lesion, and I'm there, so I'm going to biopsy. The problem is you don't know where the whole tumor is. And one thing I want you guys to experience, if you could look up here today, is I want you to be able to navigate out, but I want you to not just biopsy the center of the lesion, but I want you to experience biopsying the edges of the lesion. So we might turn on fluoro and have you biopsy here, turn the catheter a little bit, and now biopsy in a different part of the lesion. I think this becomes applicable, especially when we're in nodules maybe that are 1.5, 2 centimeters, but I still want you to experience it today in these nodules that are sub-centimeter and just prove like, hey, if I can do it in sub-centimeter. So if we think about pathology in the room, and you've given them 3 contiguous samples that are coming back with nothing, like I'm not seeing anything that leads me to believe that it's diagnostic tissue, move the catheter. Let's do something a little different. Let's tweak it, right? It's this whole definition of insanity, right? Repeating the same thing over and over. So then we move on to the first head-to-head comparison with one of the shape sensing robotic platform. When we compare that to Illumnisite, we can see that it wasn't actually Illumnisite, my apologies. This was with our super dimension technology with the digital tomosynthesis, right? So this is digital tomosynthesis ENB. And again, there's no difference here. These are statistically, I can say, oh, we beat the robot. No, these numbers are the same. And I bring this up because there's more data coming out this month where it's going to compare us Illumnisite to the robot, and they beat us by 3 points, right? So these are statistically no difference, and I think it's important to know, like, when you're comparing data, or how are we comparing it, and again, I think the clinical data is strong with all these platforms. But what I will say is we are about to announce the outcomes of our Veritas. This is the first level 1 evidence in this biopsy space, and so this is exciting. So Vanderbilt reached out to Medtronic and said, hey, we'd like to do this study. They applied for a grant. We gave them the money, and they ran the study independently. We didn't have a choice of where they went with the study, how many centers. It was 7 centers that they enrolled, community and academic. And if we look at the 2 randomized groups, so this was all prospective randomization to Illumnisite or CT guided. And you can see on the right side that 88% of these were really favoring CT guided. And again, the nodule size was 15 millimeters, which again is respectable. But I want you guys to make note of the 33% bronchus sign, because a lot of papers are showing a very, very small bronchus sign leading to the nodules, and it proves that it doesn't really matter, right? It's not an indicator necessarily of success. There's some steps that you may have to employ into procedurally, but for the most part, we haven't seen a significant decrease in diagnostic yield when the nodule is off airway, so to speak. However, users for years would say, hey, I'm only going to do this case if there's an airway leading to it. And that's not necessarily always the case. And as you'd expect, with CT guided, the actual complications, hemorrhage, pneumothorax is much greater in the CT guided. We all I think know that. The data that's been out for quite some time shows that. But at the end of the day, what really comes with this is the iatrogenic pneumothoraces that really create hospitalizations, which create a cost to the hospitals, and this is what this slide's about, right? If you translate what those costs are to the hospital, it's hospitals are eating this money, and again, this you guys been in a case with a pneumothorax yet, or a complication? Okay, yeah. Okay, so let me ask you a question. So why do you think a pneumothorax occurs?
What could have done different? We probably have left the needle right at the tip, was not too far out. I think that needle was just more out.
Do you think the needle was out further than you thought?
Yeah, than I thought.
Okay. So the reason I bring this up is because I want to show you guys how to potentially address that issue.
Yeah,
right. And this is all about how we use the C-arm, how we are really intentional, right? Like we are intentional, and we have complete knowledge of how far that needle is going out. I would agree with you. I think this is in my nearly 18 years, and I've seen analyzed hundreds of cases of pneumothorax. The number one culprit behind pneumothoraces is not understanding that biopsy tool and where it's going, right? Truly it is. And now have I seen these spontaneous pneumothoraces where just driving the scope out and we haven't even done anything because we did the sweep and all of a sudden the lung is collapsed? Yes, I've seen that too, right? That happens. So it's happened without the implementation of biopsy tools. But you guys remember, anytime you can make the case, correct me if I'm wrong here, Dr. Dunn, but you can make the case that anytime you go outside that airway, and I would bet even in your EBUS procedures, you were violating the pleura at times, right? There's the potential there as well to violate the pleura. So even when we go outside an airway, in essence, we're violating the pleura from a perspective or a sense, right? So it doesn't always have to take the idea that we are violating the pleura along the rib cage or a fissural boundary. It can happen other ways. But part of what my focus today is to show you guys every time understanding that pleural boundary 100%, right? I'm gonna spend some time on that as we go through it. And then lastly, I'd be remiss if I didn't sort of talk to the financial economic benefit of Illumnisite. This was a poster that was submitted last year by LSU, Louisiana State University, LSU out of Shreveport. They have two platforms. They have Illumnisite, they have Ion. They used both platforms. It's a teaching institution. And they did a cost analysis, and we were like, wow, this is great. Like, if you go down to this on the right side of the screen here, the results, 5-year time savings, $614,000. That's just based on 100 cases. And this doesn't even take into consideration all of the other variable costs that there actually are. They fracture more radio probes. That didn't get put in this paper, right? That when they use the robot, what the users are doing is they're putting out radio probe, and then what they'll do is they'll move the robot and fractures the radio probe. We're like, they're constantly complaining. They had an additional $30,000 in radio probe costs last year because of that. Again, they're not going to put that in a poster or paper. They see that, you know, these catheters that you use with this particular robot, they're reposable, right? So they're used multiple times. They're not always getting the full life out of them, right? So during the cleaning, they have to clean these scopes, and if they break something or something damaged, that's on them, right? So there are additional costs, and so the point is there is a value, an economic value with the Illumnisite platform that I just wanted to mention.
Is there a time saving? Did I look at the time saving if you know, Ion versus the Illumnisite?
Yeah, I mean, I think right now there's nothing published on that, although I know anecdotally there is a savings, especially with the setup, right? Especially with kind of turning room over. Okay, so let's at this point, why don't you take